Welcome everyone to today's Ask the Expert session. I'm Lori Sjogren and I'll be assisting with today's session along with a few of my colleagues. So I just have a few housekeeping notes to go over before we get started. First of all, closed captioning is available for today's session. To enable closed captioning, all you have to do is click on the closed captioning button that's found on the bottom of your screen and select the show subtitles option. Also wanted to mention that questions for our expert speaker can only be typed in the Q&A. And that Q&A button is found at the bottom of your screen. And we'll answer as many of those questions as time allows. But please do not use the chat feature that you just entered in where you're joining us from to submit any of your questions. Use the Q&A. Now, please join me in welcoming back our resident ataxia expert, Dr. Susan Perlman. Dr. Perlman is a clinical professor of neurology and director of the Ataxia Center at the UCLA Medical Center in Los Angeles. Welcome, Dr. Perlman.
Thank you so much for inviting me back. And I'm going to do my best to get through as many of the really good questions that people are asking every time. There's questions that we have good answers to. There's questions that I may not know an answer to, and I know Lori is going to keep track of some of those so that I can afterwards look things up and we'll get back to the person ideally who posted those questions. So there's usually a range of questions from clinical things to research related things. And many of the questions come from individuals with ataxia who have been surfing the internet, attempting to find information on their own, finding conflicting studies, finding information they may not understand. But a lot of the questions just come from personal experience. And I would say that half of what I know about ataxia, I've learned from my patients. Things they've shared that have helped, things they've shared that haven't helped. And this benefits the entire ataxia community. So VSW posted the first question. What is the latest on delaying the onset of SCA6 or any SCA for that matter, anything that can be done preventatively? We know that the size of the mutation in the triplet repeat expansion disorders, SCA 1, 2, 3, 6, 7, etc., the size of the mutation does determine to some extent age of onset. Smaller mutation is going to be later age of onset, bigger mutation is going to be earlier age of onset. So there is a genetic component that is relatively fixed. There are also other genetic factors in your family that could be protecting you. Anti-aging genes might alter the onset of disease in somebody, 2 or 3 people have exactly the same mutation size, different onset because of other genetic factors in the family or potentially lifestyle factors, which there's a lot of research going on now to determine the impact of diet, the impact of sleep patterns, the impact of exercise. One thing we do know in the animal models of SCA is that exercise stimulates nerve growth factors. Nerve growth factors protect nerve pathways in the brain and may delay death of a nerve pathway connection for a period of time. So I think one thing that can be done is to have a regular exercise program that includes cardio, something that will get your heart rate up and get your muscles moving. Now, EFRAT has a more research-directed question, returning to SCA3. And if we go to the NAF website, they have a wonderful pipeline that they are constantly updating with more and more companies that are interested in developing potential disease-modifying therapies for the ataxias. So there are a number of pharmaceutical companies that are focusing on SCA3. It's the most common of the SCAs in most of the areas that we are located. They cite the Biogen ASO technology, where they have developed a small moiety, antisense oligonucleotide, that can target the messenger RNA being produced for the SCA3 protein that has the mutation in it and destroy it before it can make protein. Most of the ASO technologies, the biogens and others, are non-selective. So they'll destroy messenger RNA with a mutation, but they'll also destroy messenger RNA that is normal and supports the wild type protein, the normal protein. So one of the big questions in developing such a study, and Biogen, jumped into the deep end of the pond with SCA3 on this one, is, how low can you go suppressing the normal protein before you begin to have problems because there's not enough normal protein to do the job. And that, animal studies give us some sense of that, but we just don't have a full answer to that. And I think one reason that Biogen stopped their work with their ASO and gave it back to Ionis, from whom they had gotten it, was they were concerned that if they went to the higher doses, that there would be some side effects that were not predictable. Certainly, you want to get enough of a dose that you'll get a good effect, but not so high that there's going to be bad effects, which have seen with other disorders with ASO technology. Huntington's disease is one. Most of these disease-modifying therapies that use this type of technology to destroy messenger RNA, to break up bad protein that may already be produced. They may start with Huntington's, which is fairly common. And then the next logical step for many of these companies is to go to SCA3 or others. One company that is working with Huntington's and SCA1 and SCA3 is Vico. And we've heard some good presentations from them at the meetings. And they have some things on their website that are very interesting. And for SCA3, it's not destroying the messenger RNA. For SCA3, their ASO is a splicing modifier, so that when the DNA makes the messenger RNA and the messenger RNA is packaged in order to make protein, it splices out the mutation. So you end up with a shorter piece of messenger RNA that makes a shorter protein that still is functional. So this is a very exciting approach. And for Huntington's as a parallel disease, there's another company here in the US, PTC Therapeutics, that is working on a splicing modifier for Huntington's, which could also be translated potentially to SCA3. Now, Nicole has a question. What is the life expectancy following the use of a feeding tube for somebody who has spinocerebellar ataxia? Now, not everybody with spinocerebellar ataxia loses the ability to safely swallow. Many will have swallowing problems that can be accommodated by changing the type of food, changing the way they drink liquids, to avoid aspirating food or liquid into the lungs, which is a major concern. Other individuals are so careful with modifying food and smaller bites and smaller meals that they don't get enough calories in, and they end up losing weight, which can, complicate and make your ataxia symptoms worse. So a feeding tube may become an option for someone who can't safely swallow or can't get enough calories in. So though that's usually the decision, for when to have a feeding tube. Now, once you have a feeding tube in and you restore better nutrition, it can sometimes improve ataxia symptoms. It can slow the late stage decline, so that you can remain more stable because your nutritional status is better. And I have individuals who have had feeding tubes for 5 years and are still doing, reasonably well and stably. When you reach a point in your disease where the question of a feeding tube comes up, the amount of other care a person needs may be increasing, it's always good to involve hospice. They have nurses and healthcare providers and physicians who know late stages of most deteriorating neurologic disorders, and can give you some advice there as well. Okay, Stephanie, 2 questions. Does congenital ataxia cause hypotonia? Cerebellar disorders, which can be congenital, something that you're born with developmentally, or something that's genetic that you develop, The cerebellum does control muscle tone, so that somebody who has a pure cerebellar problem, whether it's congenital or acquired, will have decreased muscle tone in the limbs that are affected. When there are other nerve pathways involved, upper motor neuron pathways or basal ganglia pathways, there could be an increase in tone that's seen. But pure cerebellar, congenital or otherwise, typically has decreased tone. And then what would the development of a child born with ataxia look like? Gross and fine motor skills, swallowing, etc. So a child that's born with a congenital ataxia, whether it's a cerebral palsy, a brain injury, whether it's a genetic congenital. And I have two families that I have been following who have congenital small cerebellums. The children, do have delayed gross and fine motor skills, but they ultimately seem to catch up. None of the children in those families has had significant problems with swallowing. And the adults have very mild ataxia. They've kind of grown through and developed their motor skills and then stabilized as adults. Maybe not, perfect coordination and balance, but certainly functional coordination and balance. So depending on the congenital cause, whether it's a genetic factor or an acquired factor in utero, the normal development in a child will go on. It just might be slowed. And working with physical therapy, occupational therapy, and speech therapy when appropriate can help to gain those important milestones. Now, here's an anonymous attendee. Is a brain MRI needed if I have a definitive genetic test diagnosis of SCA8? SCA8, predominantly cerebellar, you'd expect to see some thinning of the cerebellum on an MRI scan. And as the disease progresses, after 2 years, 3 years, 5 years, you repeat the scan, it's going to look a little smaller. The ataxia might be a little worse. So that unless you're involved in a clinical trial where they're tracking the MRI to see if their drug or treatment is improving the brain, getting a repeat MRI or even getting an MRI to begin with may not be necessary if you have a genetic diagnosis and you are absolutely sure that there's nothing else that could be going on, that you don't have hardening of the arteries, that you haven't fallen and had a head bump and had some bleeding inside your head. So that even with a genetic diagnosis, there could be factors that you notice in your performance or changes that could be quite sudden, that you don't just want to assume it's due to the SCA8. And that's when a brain MRI or CT scan can be very, very helpful. Not necessarily in establishing the diagnosis, but in ruling out other factors that could be involved. Lisa has a question. Have I seen any patients benefiting from Amantadine, and what symptoms did it help with? Wow, I just had a patient yesterday that I had a Zoom visit with, an individual with multiple system ataxia, non-genetic, who has had severe ataxia, wheelchair dependent, could use a walker only with 2 people assist and a gait belt. We started Amantadine, and her physical therapist couldn't hold back how much improvement he had seen with her balance and mobility. And that's one case. Amantadine has been used for as long as I've been seeing patients with ataxia because it was fortuitously found to help mobility in people with neurologic problems of movement coordination and balance, beginning with Parkinson's disease and then with the ataxias. It was one of the earliest drugs to be found to help symptoms in Friedreich's ataxia. I find it to be very helpful in younger kids with ataxia telangiectasia because the side effects are well known and pretty manageable for the most part. So in the patients that have benefited from Amantadine, it seems to help upright stability and balance. It seems to help tremor in some individuals. And it had a trial in multiple sclerosis to help with fatigue. And many patients with ataxia do have fatigue because of the cerebellar disorder. And potentially Amantadine could help with that as well. It's worth discussing with your neurologist So this is somebody who has SCA2 and potentially has a borderline mutation for SCA1. Both of those would be expected to affect balance, upright stability. SCA2 could have tremor, SCA1 could have tremor. So I think, amantadine remains on my list of drugs to try for symptomatic management. The list that I go through, Riluzole is usually number one. Dalfampridine or Ampera is usually number two. And then amantadine or buspirone, two older drugs, are the ones that would follow on from there. So Jane has a question. Is there a correlation between SCA3 and high blood pressure? I don't think so. I have not seen a trend in my patients. Remember, high blood pressure incidence, increases as we get older. The onset of SCA3 could be in your 30s, 40s, or later. So there could be a general correlation, but not directly related to the disease. Now, SCA3 can involve autonomic nerves. So it can involve bladder function, it can involve bowel function. It's one of the genetic disorders that mimics the non-genetic multiple system atrophy. And blood pressure instability could be part of it, where it may run high, it may run low. You start a blood pressure medicine and all of a sudden you're running too low. So I think with knowledge that SCA3 could have involvement of autonomic nerves and peripheral nerves, monitoring blood pressure, certainly if you're starting various medications, is going to be important. Here's another anonymous attendee. Could there be a benefit from longer fasts? There are signs that fasting, for instance, for 4 days, stimulates stem cells and autophagy. I've heard, and that autophagy is the ability to target abnormal proteins and break them up and remove them. I've heard that autophagy might be a process that doesn't function properly with SCA, that the abnormal protein builds up and can't be taken away. And I've heard about fasting. I've heard about intermittent fasting. I've heard about, fasting for 12 hours and, only eating within a 12-hour time frame or even longer, for the purposes of weight management and handling metabolic syndrome, etc. I don't know about the ability to stimulate stem cells. So I'm going to make a note to myself to look up fasting and its influence on stem cells, and autophagy, just to see what the basic research is. And you may have already seen some basic research about this, and I just haven't run into it myself. Okay, Mark has a question. How does a mutation from 25,000 years ago, an interesting question there, cause a new disease today? Okay. Some mutations have known to have been around for a long time. For instance, the mutation, the GAA expansion in Friedreich's ataxia, has been traced back to the Roman days, that it was felt to have originated in that Mediterranean area where the Romans were, and then it spread with them. They took the mutation with them. So how it could, and hence every place the Romans went, we have Friedreich's ataxia, a place the Romans didn't get to. Friedreich's ataxia is very rare because that unstable gene never made it there. So if there was a mutation, it could be traced back, with all the genetic technology that we have, to markers that would date it thousands of years ago. Is it possible that over this period of time, the mutation has gotten bigger, has altered in some way that makes it more detrimental, hence causing symptoms of a new disease? On the other hand, there could be very old mutations that we just haven't figured out yet. And so we see a disease, we see 20 people that seem to have the same disease, we analyze their DNA and discover that they all share a very small change in a gene that may have been present for thousands of years and could be the cause behind their ataxia, but it just wasn't recognized until we made the connection scientifically. So Mark, if you've got a reference to this, please let Lori know, and I will attempt to follow up on that as well. So we've got 25K mutations, new disease. Very good question. Now, Barton is 66 years old with teenage onset of Friedreich's. So I'm hearing somebody 66 who had onset in their teens. Typical onset of Friedreich's is between the ages of 8 and 12. Onset in your teens means that instead of having 10% of the normal frataxin protein, you might have 20% or 25%, giving you that later age of onset, which we talked about, the size of the mutation, it plays into age of onset. But also with that kind of extra percentage of frataxin protein, it can slow progression. It can reduce the risk of an early onset heart problem or severe orthopedic problems. So that was, the first sentence gives me this perspective. Now, Barton goes on to say that he's had a few years of heart problems. And as a 66-year-old, you were spared the early onset of heart problems seen in younger patients with Friedreich's. But we do know in the older patient with slower disease, in your 50s or 60s, you could develop what's called a stiff heart, where there's fibrous tissue that has infiltrated between the heart muscle fibers, making it harder for the heart to contract, giving you symptoms of cardiomyopathy. And you've also had some scoliosis, but recently diagnosed with vocal cord paralysis. The left vocal cord is paralyzed, the right vocal cord is bowed, and there's a big gap, so the vocal cords don't come together. We have seen with our Friedreich's patients, as opposed to our spinocerebellar ataxia or SCA patients, that they tend to get slowing of the vocal cords, which could reflect weakness of the vocal cords or partial paralysis, as opposed to SCA, which tends to get tremor of the vocal cords. So I think what you're experiencing with the vocal cords could be related to your Friedreich's. It could be related to other things as well. And then you're asking if it's correct that this vocal cord dysfunction is FA caused, and FA, I'm sure, is contributing. And are filler injections a viable and worthwhile treatment? Yes. They have been using fillers to plump up the vocal cords so they come together more evenly. Just like if the vocal cords are too tight, they can use Botox to relax them. So if you have been offered a filler injection, find out in detail from the ENT physician who will be administering it, the pros and cons, the risks of side effects. And if it seems that the risk-benefit balance is appropriate, I would say try it if it will improve your quality of speech. Now, Cynthia has a question. Should my doctor consider prescribing Riluzole? Okay. I already said that, when I'm looking for a symptomatic drug for garden variety ataxia, Riluzole is usually my first choice. And is asking, is it better to start before the SCA6 symptoms get worse or wait until there is progression? So Riluzole has potentially two actions. It can symptomatically help performance of the Purkinje cells in the cerebellum, but it may also have a neuroprotective effect where it can protect the cerebellar nerve cells from deteriorating under the genetic stress that the SCA6 mutation is causing, or any of the other SCA mutations. So if you start it symptomatically, you should notice within 2 months that balance is better, upright stability is better, hand coordination is better. Definitely things that people have reported symptomatically, usually within about 2 months of starting it. Now, over the long haul, there's one European study that suggests over the course of a year that they could slow progression of a mixed group of ataxia patients staying on Riluzole. So I would say if you have a genetic diagnosis or even a non-genetic ataxia, certainly if you feel that your symptoms are progressing and you can't keep up with them with physical therapy and other strategies, riluzole is very reasonable to try. However, you have to check your liver function, since it's metabolized by the liver and it could put some stress on the liver. Also, if you have dizziness as part of your ataxia, one of the side effects of riluzole is dizziness. One of the other side effects is tiredness. So, you have to kind of look at the symptoms you're experiencing, decide if you're having side effects, is the benefit better than the side effects you're having? So another anonymous person, what are the best ways to stimulate brain-derived neurotrophic factor? What kinds of sports, infrared, sauna, foods? I'm sure that if we queried, brain-derived neurotrophic factor, we could find many reports, small studies or, testimonials about the benefits. So brain-derived neurotrophic factor is a nerve growth factor. And I think I already said that cardio type exercise, getting those little ataxic mice running on their exercise wheel, does seem to increase nerve growth factors and can stabilize or improve or slow progression of a genetic ataxia. So I would say the one that I know about, nerve growth factors, and we're going to bring up, we've already had somebody ask about intermittent fasting. Certainly there's foods and there's supplements that could be stimulating this. But I think looking at brain-derived neurotrophic factor and other nerve growth factors, I'm going to do a little research and see what I can find besides exercise. Barbara, what do I think of the tau patch? I have no idea what the tau patch is. I'm going to have to look that up. And many of the questions I get from patients in clinic just talks about how well-versed they are and how willing they are to do very basic research and then bring me information that I am totally clueless about. Is there anything in Ayurvedic or Chinese medicine that might be promising? Certainly Chinese medicine, many of the interventions, some of the herbal interventions, some of the acupuncture related interventions do have an impact on the nervous system, which has been documented in the Western literature, looking at, what does acupuncture do? What are these active Chinese herbs? What are they doing? I did have one ataxia patient who was taking a Chinese herb regimen once a year for a month. And during that month, we happened to get blood work, and his liver function studies were very abnormal, most likely because of the herb that he was taking. So I think if we're looking at Chinese medicine or Ayurvedic medicine, and I've seen some, discussions of Ayurvedic medicine from India as well, you can go online and you will see websites that will discuss potential benefits, potential mechanism of action, but also discuss potential side effects. So I would say that any health regimen that has persisted for this long in those two cultures because of some perceived benefit probably has something that we can recognize in Western medicine, and we should learn more about it. Now, Dawn says, I've had SCA3 for about 3 years. I've started feeling very stiff and sore hamstrings, which affects my walking. Is there anything that can help with this? So with SCA3, it's predominantly cerebellar. It can affect eye movements. It can cause dizziness, double vision, but it may also involve other nerve pathways outside of the cerebellum, upper motor neuron pathways or basal ganglia pathways, which can cause muscle stiffness and soreness, as you have pointed out, and that could absolutely affect your walking. Can also lead to muscle cramps and pain, which can interfere with sleep. Is there anything that can be helpful for this? Massage, stretching, strengthening, acupuncture, these are all very good non-drug ways to deal with increased muscle tone. As we mentioned, cerebellar disorders typically cause decreased tone, but when other pathways are involved, tone can be increased and can give you the stiffness and soreness you're describing. So massage, stretching, and acupuncture all have a role. Topical agents that you could use together with massage, but there are prescription medications. If you can document with your neurologist that the tightness and stiffness is from the upper motor neurons as opposed to the basal ganglia neurons. There are very specific prescription drugs used at modest dose that could help relax that and get rid of that. If the pain is the bigger issue, even gabapentin, which is a very generic nerve-directed drug, can help with that as well. So another anonymous person, for people with cerebellar ataxia after stroke, is there any medication that has been used for symptomatic management of cerebellar ataxia? So a damaged cerebellum, over time, after the stroke has been completed, there will be healing that can go on for upwards of 5 years, where the remaining cerebellar nerve cells will try to reconnect, they'll grow in, they'll take over from nerve cells that have been permanently damaged. So sometimes it's just tincture of time and reinforced by physical therapy. And there are studies in stroke, that cause paralysis of an arm or a leg, where vigorous, regular exercise can, again, probably through nerve growth factors, increase recovery of nerve cells that haven't been permanently damaged. So, certainly your physical therapy regimen is going to be important. Symptomatic drugs, for most of my patients with strokes or brain damage from a brain injury, again, I'll try the same medications I'll use for genetic ataxia. I'll try Riluzole, I'll try dalfampridine, I'll try Amantadine. Sometimes I've had success trying carbidopa-levodopa, since there are pathways from the upper brain that feed into the cerebellum to stimulate its responses that are mediated by dopamine. And I've had some success with traumatic brain injury with dopamine-related drugs like carbidopa-levodopa in improving balance and coordination. So I think look at the non-drug strategies, but then look at some of the medications. Most of these you could try for 1 to 2 months and get a sense if it's going to help or not. So it's not something you have to stay on for a year and then decide, well, this has been a waste of a year. So think about, the various options, but certainly starting with non-drug strategies is a good way to do it. So Tammy is asking, I have had every test done for my mom, including Variantix ataxia repeat expansion analysis, SCA27, GeneDx genome, exome, and mitochondrial genome, and that pretty much covers the range of commercially available known genetic tests for ataxia. We still do not have a diagnosis for the dominantly inherited ataxia for my family. Do you have any suggestions for anyone who'd be willing to do a research project? There is a research project going on, and it's national. We have a group here at UCLA that's coordinating with them. A group at Baylor in Texas is working with it. And I think most of the large ataxia centers are working with the Undiagnosed Ataxia Project, where you would provide, they can send you a kit, provide a saliva sample, they'll bank your DNA and include it in the genetic studies, for finding new ataxia genes. In our population of undiagnosed, supposedly genetic ataxia individuals, about 40% are still undiagnosed, having gone through all of the commercially available tests and, many years of experimental work with our genetics group. So I would suggest contacting one of the centers that's working with the Undiagnosed Ataxia Project, and get saliva samples from any family members that are affected so that they can continue their good work at finding new ataxia genes. Sandy has a question. Her brother with SCA6 can still walk unassisted, but when he takes 3 drags of a menthol cigarette, he cannot walk at all. His balance is 0. Wow. I have heard of people who can walk fairly well with ataxia, and they have, a small glass of wine or a small beer or a small amount of alcohol, and, or they eat a sugary treat while they're sitting at a concert, and all of a sudden they can't get up. So there are definitely factors. Alcohol is well known. Simple sugars, high carbs can increase fatigability and can, take the edge off your ability to compensate for your ataxia. What else is in there besides the menthol? you would wonder if there, was some sweetening agent or something in there. And I don't know. I'm just guessing here, but I would investigate further because nicotine, I have not heard, can make ataxia worse. And it sometimes can help fatigability. So it's on my list of things I'm accumulating here that I'm going to be looking up, and I'll get back to Lori about it. So, anonymous attendee, does the acronym ARCA include FA, Canvas, etc., or is it a separate type of recessive ataxia? ARCA is short for autosomal recessive cerebellar ataxia. And with the recessive ataxias, where you need two bad genes to cause the problem, they've got two or three different numbering systems. As opposed to the dominant ataxias, which are pretty much all under the umbrella of SCA. So autosomal recessive cerebellar ataxia would include Friedreich's, would include Canvas, would include ataxia telangiectasia. It's an umbrella over those. And, there are, other classifications, but the ARCA, I think, is the broadest one right now. And it's not specific for any one form. So another anonymous question, can you tell us all the diagnostics you would do on a new patient that has come to you with one MRI that shows cerebellar ataxia? For example, blood work, genetics testing, rehabilitation interventions, etc. So any new ataxia patient that I see, I automatically make sure they have connected with rehab, physical therapy, occupational therapy, speech and swallowing therapy, to get a baseline, to get interventions when appropriate, to get advice about a home exercise program, since exercise always helps. So that's number one. Number two, I would ask them, even without knowing what type of ataxia they have, are they having pain? Are they having tremor? Are they having a symptom that there is a broad range of symptomatic medications that could be used to improve how they're feeling and improve their quality of life? Then I would look at diagnostic strategies to try to figure out why. You get a family history. You talk about, exposures they may have had to poisons or toxins, injuries they may have had, other factors that might add up to cause a multifactorial problem as opposed to a genetic problem. And there's typical blood work looking for vitamin deficiencies, poisons, toxins, other medical problems, immune system problems, bad antibodies. All of this can be identified in blood. And I like to get genetic testing for all of my ataxia patients, even if there's no family history, to either get, a screen for the common dominant ataxias, which includes the triplet repeat disorders, the SCAs, as well as some of the point mutations. It's one box on a form, you check off the box, you send the blood, and they will run it through. You can look for the common recessive ataxias, maybe a broader panel there if there's no family history. I find that, some companies will offer a combination. They'll do a tier 1, which looks for repeat expansions, which includes the dominant and the recessive repeat expansions, Friedreich's ataxia, Canvas, etc. And then they'll go to a tier 2 if those are all negative, looking at whole exome sequencing, looking at the pattern of each individual gene, that we know what it should look like. And, we hope we know what those genes do. And if there's a change in the pattern, a small tweak, a small mutation, or sometimes an obvious mutation that might help us identify a genetic factor behind the ataxia that's going on. So the usual approach is, get people involved in good rehab, symptomatic medication, ruling out acquired causes, and then genetic testing. And most of my patients, have had all of those things done. And as one of the prior questioners mentioned, you can have all the genetic testing done in the world and still not have an answer because there's still a lot we don't know about, the genetic pathways that control cerebellar function. Now, as a clinician, this is from NAMI, have I seen better results from troriluzole or dalfampridine? Depends. Troriluzole is a new formulation of riluzole, which we've already talked about. it's a prodrug that turns into riluzole in your system. So in the end, both riluzole and troriluzole, it's riluzole that's the active component. It has shown benefits for, from European studies, and troriluzole from studies, here in the United States for many of the genetic ataxias. And as I said, I also try it in non-genetic ataxia. And the only reason I might be careful about using riluzole or troriluzole if the person has significant dizziness, because that's one of the side effects and it could make that worse. But it may still be worth trying. And then dalfampridine is touted as being most helpful for episodic ataxia, where you'll have periods of time of dizziness or incoordination, and then hours or days where things are reasonably stable, and then you'll get another flare-up. And dalfampridine can stabilize that and may also help baseline coordination and balance. So some patients have had a dramatic response to dalfampridine, specifically SCOT27B, but some of my other patients as well. And troriluzole, I have a number of patients who have benefited from regular riluzole or troriluzole that they've gotten through the Biohaven program. And I think you try one, try it for a couple, 3 months, try the other, see which one works better for you. Mary, are any benefits to low-level laser therapy? I know that there is laser therapy that has been used targeting acupuncture points. I've seen that, and I've seen some publications about it. It's like laser acupuncture. And we know that stimulating acupuncture meridians, the pathways that acupuncture needles or acupressure or even the laser treatments can stimulate, can improve brain function, can reduce pain, improve muscle tone, and may improve dizziness and tremor. Ataxia itself, I'm not sure about. So there may be other laser therapies that I'm not as familiar with, and I'm going to look that up. Stephanie asking, do we see children in our clinic? I'm an adult neurologist, but because I got involved in ataxia, and specifically Friedreich's ataxia, at the beginning of my career, I ended up seeing youngsters, children in elementary age, teenagers. In some academic institutions, it's rigidly divided. Adult neurologists only see 18 and older. Pediatric neurologists only see below age 18. In our clinic, we see all ages. And I think the youngest patient I have been seeing is about age 3. So, yes, we do see children, and many of my colleagues will see a whole range of ages as well. Danielle, what are my thoughts on stem cells done outside the US? Okay, so South Korea has a stem cell project for non-genetic ataxia. Taiwan has a stem cell project for genetic ataxia, specifically ataxias type 2, 3. I think they also did 6. In the United States, Mayo Clinic is working on stem cells for non-genetic ataxia. And there are plenty of commercial stem cell programs in Mexico, in Central America, in Europe, that are probably, I don't know how well controlled they are. I don't know how safe they are. They cost money as opposed to the research programs, which you can get to try the stem cells for free. So that if you're thinking of going for stem cell treatments for a neurologic problem, I would think twice if it's not a registered research program. Now, there are stem cell treatments that are in use for joint disease. And, I've seen some of the results from that, and they may have a benefit there. But for the brain and nervous system, I think we're still, really in, where we only would trust, a program that's being done under the auspices of research. Joanne, I've just been diagnosed with SCOT27B. And you heard my talk about dalfampridine. So I'm hoping that, if you are having symptoms that you think would benefit from a drug, trying dalfampridine for aminopyridine could be very, very helpful. But exercise. So exercise for ataxia, for balance and strength. First of all, you have ataxia, it's important to keep moving. Even if your ataxia is pretty severe and walking is very difficult, any movement you get is a plus on the side of exercise. So the specific exercises that seem to work best for the ataxia component, core strengthening, and then general strengthening if you notice that you're losing some power in your legs or arms. Balance exercises, simple balance exercises like a gymnast would practice, but not that aggressive. And then rhythmic repetitive exercise or cardio. And we've already talked about that a little bit. So core strength, simple balance exercises, and then something rhythmic and repetitive, like a cardio program. Barbara, do I have any recommendations for fatigue? So number one, if you're deconditioned because you're not exercising, you will be more fatigable, on top of the fatigue that's caused by ataxia. And I think I mentioned also that there are medications that have been used for ataxia-related fatigue. Amantadine is one. There are all the medicines that are used for attention deficit disorder. Amphetamine-like drugs that people will use if they really have severe crippling fatigue and can use them sparingly. There are two approved drugs, modafinil and armodafinil, that have been used for excessive daytime sleepiness because somebody has a sleep problem and they wake up tired and fatigued. But I have also used them for just general fatigue. Even somebody who's getting a good night's sleep, their ataxia itself can fatigue them. So there's a wide variety of choices, but having a gentle, non-fatiguing exercise program could be, a very good non-drug way to improve your endurance and get rid of some of that fatigability. Cindy is asking about best solutions for leg jumping. Now, leg jumping can come from several different things that we see with ataxia. And it's typically not the cerebellum, although if you have a tremor in your legs or a tremor in your core, that could come from the cerebellum. And there are tremor medications you can use. If it's leg jumping from, let's say, an upper motor neuron involvement, where the leg spasms, it pulls up on you, or it kicks out in front of you, or it's jumping at night, you have periodic leg movements of sleep, or restless legs at night. Each of those different scenarios has different medications that can be helpful. So for instance, leg spasming and cramping during the day where your leg kicks out or your leg jumps up, often managed with drugs like baclofen or tizanidine, or just a regular stretching program to get those muscles used to being stretched and relaxed. If you're having periodic leg movements of sleep or restless legs, you can use drugs like carbidopa, levodopa, or Sinemet. Some people use baclofen or tizanidine at night. So gabapentin can be helpful for that. So there are various medications that, depending on side effects and how well they work for you, could be tried. But again, a good exercise program for the legs, including stretching, can help reduce the possibility that the legs will unexpectedly jump. Now, Bobby has a question. What is my experience with 4-aminopyridine? Okay, and this is dalfampridine. 4-AC is, or 4-AP is the old name, dalfampridine is the new name, Ampyra is the brand name. It can be compounded. This person tried it for the first time and became so ill, could not take it again. Made nystagmus much worse, lost all depth perception, really, had a terrible response. I have not heard of it making nystagmus worse, although it works on the pathways that control nystagmus. So it's possible that, you're having, maybe the dose was too high. You should try a lower dose. When you said you became ill, I think I may have had one or two people that it upset their stomach. I did have one person recently who developed a severe allergic reaction, with an itchy rash, an itchy red rash. Obviously, that person would not be taking it. But if it was a GI upset or just making the nystagmus worse, affecting your vision, maybe consider retrying it at a lower dose. It's not going to work for everybody. And the only group of people that, 9 times out of 10, it should work is Scott 27B. But I've had success with other individuals. So I would say if you can get it compounded at a lower dose, try it again. Otherwise, move on to something else. Another question from Anonymous: what specific foods should children with ataxia telangiectasia avoid to help manage their condition and promote overall health? And I know that several years ago, there was a lot of discussion in parent groups and in the medical community about any foods or medications that had an alcohol component to them. Now, obviously, you're not going to give alcohol to children, but there are prescription drugs and non-prescription drugs that have alcohol as part of what dissolves the active ingredients, and those obviously should be avoided. Foods, ataxia telangiectasia. We don't know 100%, how that mutation affects the cerebellum. We know it does. We know it affects cerebellar development and also, cerebellar health over the long haul, so that, there could be relatively normal development of the cerebellum and then dying off of some of the cerebellar nerves because of the genetic problem. We know that, AT is a cancer risk gene. We know it can affect the immune system. So if I was to look back in the literature, I'm sure I would find information about, an immune protective diet or cancer protective diets, which may have some background from those medical disciplines. However, I think the biggest problem with kids with ataxia telangiectasia is weight loss. They may have some trouble eating, but they may not be able to get enough calories, and they lose weight, which compromises muscle and can make their ataxic symptoms worse. So I would say consult with a dietitian, monitor, the child's weight. We can check out the research, for, diet as it may affect the immune system or cancer risk. And there's, a lot of good research in the general immune and cancer research areas. But I think the biggest concern with AT children is weight loss. For anybody with ataxia, I think in general, the Mediterranean diet is found to be best tolerated. That if you have a diet that's high in simple carbs, you're going to be more fatigued and your balance will probably be worse. If you shift away from simple carbs to have, more complex carbs, healthy fats, and protein, as in general, the Mediterranean diet is an example of that. It improves energy levels and can improve performance. And I'm not a dietitian, and I think I own every diet book that's ever been published. Many of them I just put on the shelf and don't look at again, just because, they don't really have a lot of science behind them. But there is good research going on, in, the role of, getting your metabolism in a stable position and then helping your neurologic problem. Another anonymous question: what can be done to help stop or slow degenerative progression, in particular with possible alcohol-induced ataxia? Well, stop consuming alcohol, number one. Even small amounts could be problematic. Assuming, and we've always assumed that once you stop whatever is damaging your cerebellum, you have ataxia, but it's not going to get worse. But we know that may not be true. That once you have damage, whether it's alcohol related or some other factor, there could be a low-grade inflammation that lingers and could cause progression of what we assumed would be a stable ataxic problem. So there is research being done in all the immune inflammatory mediated ataxias, with IVIG, plasmapheresis, and other interventions to try to reduce neural inflammation. There are drugs in the pipeline that are targeting neural inflammation. None of them have really been effective yet for the ataxic disorders, Although when you think about it, multiple sclerosis is a neuroinflammatory disorder, and they have a whole library of drugs that target neural inflammation, and you wonder their usefulness with other neurologic disorders that have an inflammatory component. So I would say stop taking in alcohol, try to get on, a good exercise program and a good healthy diet. This is your grandmother talking to you here. But I think, if you feel you're having progressive symptoms and you think your ataxia was from alcohol consumption, there could be something else going on. So definitely check it out with your neurologist. Just because you may have had a period where you were taking too much alcohol doesn't make you immune from other genetic factors that could be in play. So definitely have that checked out. And then Sean mentions his neurologist is looking into Riluzole. Concern is that most studies are in the dominant ataxias, and he has a recessive ataxia. Do I know of any studies I should look into before my appointment? I believe there was one study done with Friedreich's ataxia and Riluzole. This was a number of years ago when the European studies came out, and they weren't so sure that it was helpful. I don't think they ever published, but the fact they didn't publish it may not have done much. But the European studies of Riluzole and ataxia included dominant, recessive. I think most of the benefits that we've seen with Riluzole, this new formulation, it's been studied in the dominant ataxias. But I think the recessive ataxias, I can, check for references, recessive ataxias and Riluzole. I don't think there's going to be a lot, but I think there'll be something in the literature. And even sporadic ataxia where we don't know the cause, or ataxia from other causes of damage, could benefit from a drug like Riluzole. So it's worth a 2-month trial. And then I think Efrat has another question about SCA3. I think I answered this one already. Sylvia has a question about slurred speech. Is there a medication for slurred speech? So number one, if you have a speech problem or a speech and swallowing problem, you need to work with a speech therapist. There's no particular drug that is guaranteed to help speech, but I've had people taking Riluzole who have said their speech is better. I have people with SCA27B who go on dalfampridine and their speech is better. So depending on what has altered your speech, I have some people taking low-dose Prozac and it seems to help speech and swallowing. So I think it's important to first connect with the non-drug strategies. Acupuncture, very reasonable. You'll know within 6 treatments if it's going to be doing anything. If you wanted to see me in consultation or any one of the ataxia docs, they have some good ataxia docs in Canada, and in other places that may be closer to you geographically, we could assess you and then decide about a trial of dalfampridine. Danny has a question, 71, and has been diagnosed with SCA43. Where can I find information on progression of this variety? There is a website called the Neuromuscular Homepage. And if you type in Neuromuscular Homepage, it will take you to that website. You then click on cerebellar, and they will have dominant ataxias, and you scroll down for SCA43, click on SCA43, and it will give you the updated research information that has been published about types of symptoms, progression, and any research that might be being done on it. So the neuromuscular homepage is a terrific resource, not just for doctors. And then we have one final question from Daniel. Could swallowing issues be related to balance issues? Yes, both upright stability, standing and walking, and swallowing and speech are controlled by the midline cerebellum. So if you have a form of ataxia that's affecting the midline cerebellum, causing balance and standing problems, swallowing and speech could also be affected. However, there are many other things that could affect your swallowing. Acid reflux can cause problems with swallowing. So be sure to discuss it in detail with your doctor before you just assume it's due it's due to the ataxia. And oh yeah, one last question about ataxia telangiectasia. Children and adults with AT are sensitive to sun exposure, so they should wear hats, sunscreen, and avoid extensive direct exposure to the sun. And I think we've run out of time. A lot of really good questions, and I have a long list of things I'm going to be double checking with Lori on, so we can, maybe have a chat, thing on the NAF website, follow up questions from the webinar.
Yes, absolutely. I followed along on your notes as well, so hopefully they match. But ton of great questions today. Thank you all so much for all of your questions. And thank you, Dr. Perlman, for joining us. Today's webinar was recorded, so the recording of today's webinar will be available soon. And we hope to see you all next time for the next Ask the Expert session with Dr. Susan Perlman. Take care, everyone.
Take care.